Welcome. My name is Glenn Robertson from Specialist Hypnotherapy. I'm also the administrator for the Australian ARFID support group. I'm often asked two key questions in relation to ARFID. The first one, what is ARFID? And the second one is, what are the causes, what are the key triggers for ARFID? ARFID is an acronym for Avoidant Restrictive Food Intake Disorder, and in the past would have been referred to as selective eating disorder. ARFID is not fussy eating. They're absolutely two separate things. Yes, fussy eating is a real thing, and a large number of children will go through that phase when they're quite young. ARFID is not fussy eating. ARFID is, for all intents and purposes, a phobic reaction to food. And the sort of reaction that you can see in the ARFID sufferer is if they are presented or try a food outside what they consider to be their safe range of foods. You'll see heightened anxiety, there may be tantrum, there may be tears, there may even be gagging or vomiting involved. Those safe group of foods may be as low as 0. Some children are actually fed through tubes, through nasal tubes, gastric tubes. It may be 2 or 3, it may be 10 foods or 20, but the key criteria is that there are a known amount of safe foods, and the ARFID sufferer really struggles to go outside of those safe list of foods. Those foods are typically high sugar, carbohydrate type foods, what we'd refer to as like a toddler diet. They might consist of things like chicken nuggets, hot chips, crisps, white bread, maybe with some condiment, dry cereal, maybe milk, maybe not, a little bit of ice cream, chocolates and sweet things are quite popular. The aversion typically goes towards vegetables, fruits and proteins. And because the aversion is on those vegetables, fruits and proteins, a lot of ARFID sufferers, one of the key criteria to be labelled ARFID is this low nutritional intake, where the fuel that's coming into the body is really not sufficient to give them enough energy and vitality and to maintain their nutritional level. So that's one of the key criterias of ARFID. So how does it start and when does it start? Typically between 0 and 4 years of age. That doesn't mean that it can't start later. In fact, certainly come across instances within adolescents and adults, but predominantly very early in life it starts. How does it start? I like to refer to it as a mini trauma in some regards, and it's even a trauma that the adult or the carer may not recognise or may not be around to see. Sometimes it's just the movement from weaning from liquids to solids. Maybe that could have even been a bit of puree or a small chunk of food was lodged in the throat. That protective inner part jumps in, clears the throat because its job is to maintain the safety and sanctity of the organism. Absolutely needs the organism to survive and to maintain and to be alive. It jumps in and clears the throat, gets very protective and says we don't want that to happen again. It's on high alert, and it's on high alert for the type of food that it believes was causing that problem. It doesn't take much to tip a young child over the edge between 0 and 4 years of age, and animals and food are the two key culprits. We see many adults that are still scared of birds and spiders and dogs and cats, and something happened in their childhood and this protective part jumped in and made a decision that that animal was a problem, in the same way that that protective part made that same decision when food presented to be a problem to that person. Some of the other triggers might have been that the child has gastro, has glandular fever, has tonsillitis, might have been a vaccination. The reaction to the vaccination in the body made the body feel unwell. The protective part made the link between what was the last thing in the body. Oh, I think it was food, therefore food made us unwell, therefore it's on high alert for food in the future. It doesn't take much to tip us over the edge. And when we're young, when we're that young, thank goodness for that survival mechanism, that inbuilt survival mechanism. It gets it right most of the time. For the ARFID sufferer, that survival mechanism never switched off. It never grew up, it never upgraded. As they got older, it was locked in time, still protecting them in that old way. And that's one of the key components of creating this phobic response that doesn't change. That's why that we can think logically, and that's why the ARFID sufferer can say, I really would like to try that food, that would be something I would really like to try, it looks good, I think it would be fine. But when they physically go to pick it up and put it in their mouth, this internal protective part comes to the fore and says, no, forget it. We're not going there, you're not putting that in. Remember last time that caused us trouble. So there's a real conflict between what the ARFID sufferer wants and what this protective mechanism inside is delivering. In time, that in fact may deliver an absolute disinterest in food. And what happens to a lot of ARFID sufferers is exactly that they look absolutely disinterested because they're worn out, this internal struggle between wanting to try something, but this part saying, no, we're not going there because there's a danger involved with it. And therefore the conscious mind just doesn't go there, it doesn't create stress for itself anymore. So typically that's ARFID explained in a nutshell. A couple of other things I just want to touch on very briefly. It's also some other questions that have been brought up in relation to Asperger's, children on the spectrum, ASD, also in relation to sensory processing and hypermobility. Asperger's or ASD, part of that assessment or a child that's been assessed with that criteria, food can be a challenge in itself for the ASD child. What we would need to determine is the food issue greater than normal? Certainly children with ASD can present with ARFID, and it's quite logical to help the child who has ASD to overcome their ARFID issue. Sensory processing is another one. You know, children are born with sensory processing issues, whether that's touch, whether it's olfactory, whether it's the texture, whether it's the taste. Now, the fuel that drives sensory processing is fear and anxiety. And if they have a fearful or anxious experience around food, then that's multiplied by the insistence of them having this sensory processing issue. Just because they have sensory processing, they may also have ARFID as well. Doesn't preclude them from also having some benefit from some therapy to reduce the fear and reduce the anxiety, and therefore make their sensory processing something that's quite okay and won't get in the way of them trying food. In the same way that hypermobility, very similar to sensory processing. I hope it's been a very brief overall sort of capture of what is ARFID and what are the key triggers of ARFID. I hope that's been of use to you, and I'll certainly post some more videos shortly focusing on some key areas of ARFID, and thank you.